Today we will discuss the management option of the infertility patient. After arriving at a diagnosis of most probable cause of the infertility, now we have to think about the management option. Whether that patient, we have to decide whether this patient requires conservative treatment, expectant treatment, any medical treatment is required, correction of the lifestyle disorder is required, that is just sufficient, some minor surgical procedure is required. So we have to decide at this point whether this patient requires any pre-treatment or directly the proper ovulation induction should be started. We will discuss in detail step by step, but today in general we will have an overview of management options. So if the duration of the infertility is less than 3 years and age of the patient is less than 30, there are no ovulatory disturbances, semen is normal, then just treat the positive causative factor and wait naturally at least for a year. If she doesn't conceive, then she requires active treatment. The first attention should be paid if any underlying hormonal disturbances is there or not. So if the patient is having hypothyroidism, without delay the treatment should be started. Hypothyroidism affect infertility in a multiple way, which we'll be discussing some other time. Many times hypothyroidism and hyperprolactinemia goes hand in hand. So even if there is no galacturia, the prolactin should be estimated. And if the prolactin level is high, maybe more than 30, 40, the treatment should be started. If there are obvious clinical signs of hyperandrogenism, especially in cases of PCOS, and you prove it by a serum estimation of free testosterone level, total testosterone, DHEA, 17-hydroxyprogesterone, then you would like to start treatment for hyperandrogenism, because hyperandrogenism affects locally, it spoils intrafollicular environment, it affects HPO axis, it increases the insulin resistance, it affects in a multiple way. If patient is obese, PCOS, history of diabetes, and you have measured insulin and you found that patient is got hyperinsulinemia or glucose tolerance, then you would like to give metformin for that. Apart from the hormonal disturbances, you should pay attention on the correction of the lifestyle. If patient is grossly obese, it is always desirable to lose the weight, and ideally the BMI should be less than 27 when patient should be offered fertility treatment. Of course, it is not very strict criteria. You cannot, if the patient is of advanced age, you cannot postpone the fertility treatment just because she is obese. If patient is smoking, she should stop smoking. If patient is consuming too much of coffee, then it should be restricted. Alcohol also should be minimized or stopped. Stress is a very important factor causing hypothalamic disturbances, and by that it causes ovulation disturbances. So, stress management is very important. If patient is consuming too much of junk food, she should be advised against that. Especially the male patient. If there is a clinically palpable varicocele with compromised semen, should be offered varicocele operation. The male patient should be advised to advise against using tight underwear. They should have cold bath, avoid very hot water bath, prolonged sitting, prolonged riding bike should be avoided. Very interesting recent study says that work pressure doesn't affect a semen quality, but it is a domestic stress which is important, which affects the sperm quality. After correcting lifestyle or any hormonal disturbances, any minor procedure for the correction and for the enhancement of the fertility is required should be done. A few examples, like if the patient has got cervical erosion, cauterization should be done. Cryocauterization is always preferable. Before that, pap smear should be taken. After cauterization, patient will have excessive discharge for next at least 3 to 4 weeks. So patient should be warned about that, and patient should avoid intercourse during that period. If there is polyp coming from the cervix, the polypectomy should be done. If we find that there is some obvious uterine or cervical problem, or because of some diagnostic tubal patency test or some other thing, we have planned for laparoscopy. Then while doing laparoscopy and hysteroscopy, if we come across adhesions, then histoscopic adhesiolysis. If you find that the cavity of the uterus is very narrow, then lateral metroplasty should be offered. Smallest septum causes disturbances, repeated abortions, implantation failure. So, septoplasty, septum resection should be done. If there is endometrial polyp, polypectomy should be done. Endometrial myoma should be resected. If there is a connual block, the cannulation of the tube should be tried. Whenever you are doing histoscopic surgery, try avoiding using energy sources. The cold knife cutting or cutting with the scissor is always preferable. And if at all the usage of the energy sources is required, bipolar should be safe and preferable. Saline bipolar. While doing laparoscopy, if any adhesions which are spoiling the TO relationship, it should be corrected. If any chocolate cyst you come across while doing laparoscopy, it should be excised. But try to minimize using electric currents, energy sources, because it affects the ovarian reserve severely. If there is any ovarian cyst, it should be excised. Normally, we were very enthusiastic in doing PCO drilling earlier, but now we have realized that it is not required in too many cases. If incidentally you are doing laparoscopy for some other reason and you come across PCOS, then 3 to 4 puncture drilling should can be done. It will have some beneficial effect while stimulation, but just for the purpose, but because the patient has got PCOS, just specially for PCO drilling, laparoscopy should not be done. If there are peri-ovarian adhesion, variolysis should be done. If you come across the endometrial spots, then fulguration should be done. If there are myoma, myomectomy should be done. So in general, after correction, if patient is young, there are no ovulatory disturbances, normal semen, then patient can be kept conservative, can be reassured, can try by themselves for maybe a year or so. If it is not successful, then active treatment is to be initiated. Suppose semen is compromised. If it is severely compromised, then treatment should be started immediately. Patient should be offered IUI or ICSI depending on the semen parameter. If it is mildly compromised, then patient should be investigated further. Additives, nutrient like coenzyme Q10, zinc, vitamin E, etc. can be tried to improvise the semen parameter. If there is a cervical factor persistent after even correction, still recurrent erosions are there, then IUI should be offered in such patient. If there are ovulatory disturbances, then depending on the cause of ovulatory disturbances, the treatment of control ovarian stimulation with ovulation trigger, adjuvants, gonadotropin, IUI, IVF should be offered accordingly, step by step. If the tubal factor tubes are affected, you must understand the tubal patency doesn't imply the tubal functionality. Many times tubes are patent, but tubes are not functionally okay. But unfortunately, there are no good tests which can tell you the function of the tubes. So if you do HSG and if you find out that tubes are patent, still if she is not conceiving, then better would be a laparoscopy, looking the exterior of the tube and make out whether tubes are looking functionally normal or not. Chlamydial test can be done, but there are a lot of false positivity with chlamydia trachomatis. So that is the reason why we do not, plus it is a costly test. So we do not include that in a routine investigation. But yes, when you are suspecting chronic pelvic inflammation, this test should be done. Because if it is proved that the patient has been affected by chlamydia, the single exposure to chlamydial infects reduced fertility by 60%. So if there are severe tubal factor, patient should be offered ART. If it is mild factor, can be kept conservative. Now coming to unexplained. Suppose you have found that the patient is suffering from unexplained infertility. So very interesting fact about unexplained infertility. If you do not do anything, then also patient has got chances of success about 2 to 4%. If you do only IUI, then also chances are 2 to 4%. If you use clomiphene with time intercourse, the chances are 2 to 4%. If you use gonadotropin with time intercourse, chances are 5 to 7%. If you do clomiphene with IUI, the success rate is 5 to 10%. If you do clomiphene with IUI, success rate is 7 to 10%. If you do IVF, success is 25 to 45%. So in nutshell, unexplained fertility is truly undiagnosed infertility where non-ART treatment doesn't give much success. So patient should not be pulled unnecessarily on conservative treatment. If patient doesn't conceive in 4 to 6 cycles of IUI, then immediately, even if the patient is young, patient should be offered IVF treatment. Now few words about AKT. Normally, the tube in Indian scenario, there are a lot of center who offer AKT to a patient with the slightest suspicion without any laboratory investigation. I would say it is justifiable. There are a lot of people who believe that no, AKT should not be offered like this. Normally, I try to investigate laboratory investigation like TB, PCR, endometrial, but I do not rely completely on them. If I have got a clinical picture of the patient where where I'm doing sonography, patient is complaining of chronic lower abdominal pain, discharge, patient is malnourished, there is no is poorly weight patient. The patient has got when you're doing transvaginal sonography, there is increased vascularity of the uterus, there is free fluid in the pouch of Douglas, the patient has got oligomenorrhea, scanty menstruation, chronic discharge from the private part, and the endometrial growth is not proper. So these are the patients where I would like to start AKT empirically. While doing laparoscopy, if I come across some tubal problem and if I can rule out chronic pelvic inflammatory disease because of some other reason or endometriosis, I would like to start AKT on this patient. Try AKT for at least 3 months. Many times, just by starting AKT, patient conceives because tuberculosis affects at multiple places. This we will discuss in some separate talk, the effect of tuberculosis on infertility. So this is in nutshell what is to be done and how to plan the treatment of infertility patient. Thank you.